I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's virtual events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's virtual events series.
Good afternoon, everyone. Thank you so much for joining us today. My name is Rebecca Kiesling, and I am the Director of Programs at the Benjamin Rush Institute. This is, I think, our 25th episode of the virtual event series, which we began in response to the COVID-19 pandemic. We, as medical schools, closed and went completely virtual. So did all of our medical school events. And we started this virtual event series rather seamlessly because we were already streaming events between campuses. So this was a great idea that some of our students helped us come up with in order to continue that education of free market healthcare alternatives to what they are receiving in medical school. That education, primarily funded by big business, big government, big pharmaceutical companies, does rarely ever contain information that they need to really complete their education. And that's the mission of the Benjamin Rush Institute. I am very excited about today's speaker because he is going to help us explain that. What are those free market healthcare alternatives? What does that mean? And why is it so important? It's probably the question I get asked the most by students, because students do believe in the doctor-patient relationship, and they know that government interference in their training and what they're being trained to do isn't the best way. It's not what needs to be done. And the government and regulations don't belong in that room. So how does that work? And how do they explain it to other students? Because they are our ambassadors. These student leaders that we have on medical school campuses all over the country and internationally really are the ambassadors we have for free market healthcare. So I am very excited. Dr. Daniel Sem was described to me by a former teacher who is now a chapter leader as an entrepreneur. And reading through his biography, I really can't describe him in any other way. Dr. Daniel Sem has over 25 years of experience in healthcare entrepreneurship and innovation, first in the biotechnology sector, then in academia. He has over 70 published papers and book chapters, 10 issued patents, and has co-founded several companies. In 2020, he published the book Purple Solutions, a bipartisan roadmap to better healthcare in America, which you can learn more about at purplesolutions.org. Dr. Sem works extensively with universities, industries, and government in Southeast Wisconsin to build shared healthcare innovation and commercialization resources for that region. He received his PhD in biochemistry from University of Wisconsin-Madison and then worked in biotechnology in San Diego. He also has a law and MBA degrees from Marquette and has acquired a passion for healthcare policy, thank goodness, blending law, healthcare, ethics, and sound economics. Dr. Sem joined the faculty at Marquette and served as an assistant and then associate professor of organic chemistry before joining where he is now, Concordia University's New School of Pharmacy in 2011. He is now the Dean of Business in July, which he started in July of 2016. He is still a part of the Department of Pharmaceutical Sciences. He's also CEO of Bridge to Cures, and co-founder and director of the Remedium Exchange, RX think tank, whose goal is to provide the information, resources, and support to policymakers, healthcare there's patients and providers to help them consumerize healthcare. We're a great fit. I personally love that he also is, obviously with his background, a big advocate of medical students learning more, getting more business knowledge while they're in medical school, which if you've been, and there are quite a few repeats, if you know, that's my big soapbox. My soapbox is pretty high. Medical students need more business knowledge when they come out of medical school. So please ask all of your questions. We are streaming this in 2 schools right now that are completely virtual. Our students have either gone through finals, graduated, or are in finals right now. So this is one of the most highly requested videos that I have ever done. So I'm very excited about this. Ask your questions. You can put them here on Zoom, on Facebook, which is working this time. And students, you can also text them to me. So very excited. And I'm going to turn it over to Dr. Sem now.
Thanks, Rebecca. It's really an honor to speak with all of you. I love the Benjamin Rush Institute. I only found out about it this last year, and I love the values. I'm all about empowering the patient-physician interface, and I'll talk about why I think that works best if there's less government, and frankly, for that matter, less control of large corporate interests. But I am an entrepreneur at heart and passionate. As Rebecca was telling my background, it reminded me of my organic chemistry days, which is maybe how I got my passion and support for physicians in training. Years ago, I had thought about going that route career-wise, but I went a different route, and now I'm the biggest advocate in the world for empowering physicians and patients. So let me share my slides. So again, I'm a huge fan of Benjamin Rush Institute. I'm honored that Rebecca included me. I'd love to help in the future in any ways. And if any of you have questions, please ask them today, as well as in the future. If you're viewing this after the fact, please feel free to email me. I'm all about trying to support you as up and rising physicians. The cynical side of Dan is I can't change people who have been in the profession for many years, but what we can do is provide a more balanced training and information for up and coming physicians. And over the years, I've sort of moved strangely from organic chemistry to business. I've been involved in a lot of startups, as Rebecca mentioned, and now I serve as Dean of Business at Concordia. So if any of you are interested in blending business with medical school, I'd love to talk to you about that as well. Love if you did it at Concordia, but do it anywhere. I think business and economic training for a physician is really important for reasons that I'll talk about in a bit. And I did write a book, Purple Solutions, and in purple because it's red and blue. So the Republican and the Democrat end of things. I started writing this book in December of 2019 in China, of all things. I was there in China teaching, unbeknownst to me when the COVID was breaking out. And since then, the world has become far more polarized than it was even then. So people critique me for dreaming that we can actually have political compromise between Democrats and Republicans. And it's a sad state of affairs that we're at. But I do think that the best solution to healthcare is going to involve a little bit from both sides. So whether or not Democrats and Republicans will ever talk to each other, and I hope someday they do, I want to present the nuggets of what's good from both sides. And I want to do that based on a thinking of sound economic principles. So starting on the red end of the spectrum, what is associated with the Republicans is a need to have what I would call markets, free markets. And I would argue we've never had free markets in healthcare. Maybe 100 years ago, before we had insurance, we had something like free markets. Right now, we have a reimbursement-driven model to healthcare, whether it's paid for by the government through Medicare, Medicaid, or whether it's paid for by insurance. But the bottom line is the physician and the patient have really no say in the economics and decision making for a lot of healthcare. And I'll talk about what I mean by that specifically in a bit. But I think an argument on the red end of the spectrum is to think about maybe do away with insurance the way that we're thinking about insurance right now. Really, the way healthcare insurance works is it's a prepayment for all your healthcare needs, and you're empowering other people to make all the decisions. It's not insurance. It's not meant to handle just catastrophic things. It's meant to handle everything. So maybe we should think about a new model where we have direct pay for care, just pay cash, credit card. And then for more catastrophic things, we use insurance. So let me make a case for that. Although there's a book called Catastrophic Care that I'll talk about in a bit that makes a really strong case for doing that. And that kind of model was actually used in Singapore and other countries with great success. To have markets, you need to have some price transparency. You need to be able to know how much things cost, and then you can shop. You can decide, or your doctor can decide, where do I get my MRI? Should I use the one that's internal to the hospital and pay $3,000, which is purely arbitrary, by the way? Or should I use one of these external providers that offer from $600, $800? You should be able to do that. Right now, you're not able to do that. And as a physician, you're not given that information. So we need to know how much things cost, and we need to be able to shop in a logical kind of way. And I think for all of this to work well, we need to have a little bit more mobile access to our medical records without looking for my cell phone. But it would be nice to have everything controllable in the hands of the patient and the physician. And there were regulations that went into place this year that are allowing that. Right now, medical records are sort of, aside from the fact that physicians don't like doing them, they're, I would argue, used as sort of an anti-competitive tool. It's very hard to get your medical records from one hospital where your provider is and go somewhere else. You know, it's like pulling teeth. Yes, in theory, we own it, but we don't really have ready access to it. So we should have more ready access to our medical records. Regulations have been put in place to allow that this year. We should have more ready access to telehealth, so we can get healthcare that way. COVID enabled that in a really big way this last year. Of course, you can't do everything by telehealth. And also there should be lower barriers to healthcare innovation. It is next to impossible for somebody to innovate in how we deliver healthcare because there are so many regulations that get in the way of anything you want to do, not the least of which is telehealth. You know, you can't provide medical services across state lines. So if you have a network of physicians providing care by telehealth, the regulations prevent you from doing this. Now, these and likewise, HIPAA regulations, which are very well intended for privacy protection, have also made it impossible previously to provide care by Zoom and other mechanisms like that. COVID relaxed those. I have talked to many providers, from physicians to nurse practitioners, to occupational therapists, whether they are Republicans or Democrats, all of them universally were pleased with the loosening of regulations during COVID that empowered more healthcare delivery by telehealth. And then related to the idea of moving away from the insurance model is the concept that what if we actually paid cash for things, you know, a doctor visit actually would only cost about $100. What if we had an HSA account that was a little bit more free than we have right now, and that could be used to purchase healthcare directly? That would be a much more efficient model, and I'll talk about why in a little bit. And if you want to argue that we should have some sort of safety net, universal care, maybe that could be government-sponsored baseline level of money that goes into an HSA account. So that kind of gets into the blue end, or what would be associated with the Democratic end of the political spectrum, is the concept of having some sort of universal healthcare, that it's the humane thing to do. People will argue that good healthcare is a human right. I don't want to get into whether it is a human right or not. I think it is the right thing to do to take care of each other and to make sure we have a baseline of healthcare. So I think we should try to do the right thing as a society. But the best way to do that is the question. So right now we have, even through the Affordable Care Act, Obamacare, we have what is basically high deductible plans and tiered. So we have levels. It's not universal per se, and we have tiers. So there's the different bronze and so on levels. So an argument could be that we should provide a baseline tier, and I guess that's what the Biden administration is talking about, at no cost or minimal cost. And I would argue that if we do that, unlike Canada and the UK, we should allow people to buy additional tiers of coverage and to go to the private market. Canada does not do that. Canada requires you to use the government-sponsored care, and that's why over 60,000 people a year leave Canada to get healthcare, is because they don't want to wait and they don't want to be told what they can and can't do. So countries like Switzerland and Germany and others, and New Zealand and Singapore actually has a really good model as well. They don't restrict in that kind of way. So I would argue if you're going to be a fan of something universal, just make sure you don't completely rule out private markets and competition, because that's a problem. So the other thing is unique to America and say Japan since World War II is that healthcare is linked to employment. One benefit of doing some variation of what I'm talking about here is delinking healthcare insurance from employment, because the cost of healthcare is skyrocketing. And many have argued that's the main reason for wage stagnation in the US. Really, salaries have not increased for 10 and 20 years in the US beyond inflation. Many argue entirely because of healthcare costs, because employers have to pay for that. That is increasing far above the rate of inflation. And employers are trying to cover that cost instead of compensating employees through salary increases. Also, people are working in jobs largely because they need healthcare insurance that prevents them from leaving their jobs and being entrepreneurs. They're afraid, especially when you have kids. I have 3 kids. You quit your job to start a company and take a risk, a financial risk. Well, that's all well and good. But if you're putting the healthcare support of your family at risk, you hesitate. So if we had something healthcare wise that was disconnected from employment, that would be good. And that connection to employment really is relatively new. But again, my argument is if you want some sort of universal healthcare, it would be a bad thing to just have universal government sponsored healthcare and no other options, which is the Medicare for all option. So I think that is sort of the opposite of a free market approach. I think, if you want to compromise, then we have something universal, but we also have markets and tiers that can be purchased. My background's in pharmaceuticals. Someday, if you guys want another talk, I would love to talk to you about pharmaceuticals and drug prices and that sort of thing. I'm not going to cover that today, though. So kind of back to fundamentals in economics here. So I would argue that the big problem from which everything else stems in America for healthcare, because we have incredible healthcare, we have incredible doctors, we have incredible technology. The issue is the cost is getting out of control, and the cost gets to issues of access because of affordability. So if you look at the plot on the right, which is a little bit outdated, the US is about double what every other country in the world is, every other developed country in the world in terms of percent of GDP and about how much is being spent. Right now, we're about 18% of GDP, and the US spends per capita. Now it's, I think, closer to $12,000 per person. So you are paying $12,000 per person. Now we can say, okay, we're going to have government-sponsored care. It's not like the government magically makes money. It's your money. It's your tax dollars. So whether the government pays, the insurance company pays, or you pay, it's $12,000. So it really doesn't matter who we're saying pays, because no matter what, you're paying. So it would be nice if you had some say in it rather than delegating it to somebody else, like an insurance company. And the plot on the left shows the increase since 1970. So since Medicare and Medicaid went into effect in the 1960s and the government took a lot of control over insurance, healthcare has skyrocketed in cost. So it was about $1,700 per person in today's dollars versus $9,000, actually more than $10,000 now. So it's been constantly increasing. Now, there are a lot of reasons for that, and I'm going to make a case to you that a big reason for that is a lack of functioning markets. There are really no functioning markets. There are markets for insurance, so to speak, but really no markets for actual purchasing of healthcare. There's a lack of transparency, and the fact that pricing is arbitrary leads to this huge amount of price arbitrage and inflated prices where overhead is basically included. This is why it might cost you $500 for Tylenol in the hospital ER, whereas you go to the drugstore and it's less than $1. So you're paying for overhead. So some of that overhead is, hospitals, interestingly, are nonprofits. I would question the logic of that. All that means is that any excess revenue they get has to be folded back in to beautiful new buildings and administrative staff and whatever. So you look at the plot on the right here, look at the increase in number of physicians is sort of the dark gray, whereas the number of hospital administrators is in the light gray. And so which correlates with the increase in spending on healthcare as well. So we are paying for some big bureaucracy that includes a lot of administrators, a lot of buildings. And I don't mean to suggest that it's intentionally nefarious. I just mean because there are no market forces to watch prices, and which is the whole idea of capitalism, by the way, and Adam Smith. Because there's none of that, there's no controls on price, so it just escalates. There are no forces to constrain it. It's out of control. So we need to rethink how we do healthcare in America, how we manage it. So Steve Klasko, CEO of Thomas Jefferson University and of Thomas Jefferson Hospitals. He's ranked the number 2 thought leader in healthcare policy in the US. We had him speak at our Healthcare Economics Summit last July. He likes to say that basically we need to tear down what we have. It's not a matter of incremental change. We need to sort of rethink what we have entirely. And what could be driving that is, I think, an empowerment of physicians and patients, a consumerization. So let the decision-making and the power happen at that level, which is what Benjamin Rush is all about. So it's like, I was so happy when I found BRI. So the consumer-led revolution is what we need. And I think, COVID might have accelerated that. So one of the very few times in my life, I will quote Vladimir Lenin. He said, there are decades where nothing happens, and there are weeks where decades happen. So, you think about some of the changes that happened during COVID. I would argue when we look back 10 years from now, we're going to see that there were big disruptions that started this year. So, and certainly part of it was the movement towards telehealth, but other things as well. And I wrote an op-ed in the Milwaukee Journal Sentinel on this exact topic as well. So, healthcare costs, by the way, 33% of healthcare costs are linked to hospital care and associated services there. So that's about half of all healthcare costs. That is way inflated. We felt the pain of that when COVID was shutting down hospitals and elective surgeries. But I would argue, and I've talked to many direct primary care physicians that are offering better care, and they are much happier as physicians offering care when it's direct primary care without this thing we call the medical industrial complex. The big providers that are merging and basically becoming monopolistic and frankly suck physicians in to this big machine. And before you know it, you're just struggling to stay on top of the high throughput of patients coming through. You're paid, or it used to be until recently, you are compensated through these relative value units. So the more, things that you treat and diagnoses that you code, and there is this issue with upcoding in the medical records, the more you get paid. So you're basically sucked into this, medical industrial complex that you never knew existed. And 5-10 years into it, you're like, what have I got myself into? So, there are a lot of physicians that are trying to break free of that, and they're doing that through direct primary care and other things. So, and again, I'm not a conspiracy theorist. I'm not saying there's some big vendetta out there in terms of how we do healthcare in America. We just stumbled into it, and there's greater number of mergers and acquisitions by the big providers. And that is not, in my opinion, good for healthcare. And the physicians I know that have done direct primary care agree entirely. So let me talk a little bit about the issues with lack of price transparency. Because, I talk about this stuff, people say, yeah, but healthcare is different than other, economic markets. You're having a heart attack, you're not going to shop for the best hospital. Of course you're not. You're having a heart attack, you're going to go where they take you. But there are many things that are not that urgent, like MRIs. So just use that as an example. So look at this variation in prices of MRIs on the right. So you can get a good MRI for less than $500, or you can pay up to $3,000. You would think there's a correlation between quality and the price of the MRI. There have been studies that have shown there's an inverse correlation, if anything. That quality is not correlated with price. Why is that? Who cares about price? The price is negotiated by the provider, who has incredible negotiating power with the insurance company. And the provider is folding in all of their excessive overhead costs, and they charge more in some areas and less in other areas. It's kind of arbitrary. but they need to cover their large overhead, which a smaller physician group would not have. So this lack of consumers, and I'm including the physician in this, is leading to, just a complete lack of awareness of how much things cost. Now, you're a physician. You didn't go into this for business reasons. You love medicine and you love helping people. I would just argue that, you cannot care about the cost of things, but just know that people go into bankruptcy. They have debt. This is the largest reason for bankruptcy and a large reason for suicide rates is the high cost of healthcare. So I would say, please don't ignore the economic aspect of taking care of your patients. I think you have a duty to care about that for them. Now, years ago, patients didn't worry about an overpriced MRI, $3,000 when it should be $800. But now with the high deductible plans, they actually have to pay that. I have a pretty decent salary. You give me a $2,000 bill for something I didn't expect, I can probably find the money. The average American cannot find $1,500 or $2,000. So this is just wrong. And so the fact that the pricing is arbitrary to deal with an overhead that you're never exposed to, neither the patient nor the physician knows anything about this. In fact, physicians are punished in a fiduciary kind of way if they refer out of the network. You're told that's because it's better to have coordinated care in a network, and it is nice to have coordinated care. But you don't know that the provider that's paying your salary is charging more for the MRI than somebody else who has just as good a one. And it's all done through the EMR. It's anti-competitive. So look at the price of surgeries varying from $39,000 to $237,000. This is just one random article. There are hundreds of articles on this topic. This has led to medical tourism as well. So the numbers I gave you so far are within the US, but if you look outside the US, for different surgeries, heart bypass, angioplasty, knee replacement, your knee-jerk reaction might be, well, you're getting a much better knee replacement in the US versus India, Singapore, Mexico. That's not always true, actually. And it's not just because physicians and so on are paid less. It's because we have this big bureaucracy in the US that's anti-competitive, this thing called the medical industrial complex. That term, the medical industrial complex, by the way, is something that is talked about a lot. And in my book, there's a whole chapter on it written by the former president of the American Medical Association, Barbara McInerney. She is a huge advocate for physician empowerment, and she is very much opposed to what she calls the medical industrial complex that is sort of causing these problems. In fact, she had a lawsuit that she had against a large provider that was trying to put small physician groups out of work, squeeze them out in an anti-competitive way. She was hoping, as president of the AMA, that she could sort of push this forward in a way to better empower physicians. So the large medical industrial complex keeps things internal, charges excessive prices through a reimbursement model. Nobody knows the prices. You go into the doctor, you get taken care of what you need taken care of, and then you get that wonderfully large surprise medical bill in a month or two, which is kind of useless because they tell you all these costs and they don't quite tell you what you need to pay, and you're really scared, and then you finally get the bill of what you pay. But the issue here, in my mind, in part, is you as a patient have no idea how much things are going to cost you later. Probably your physician, my physician has done this to me, says, don't worry about it. Your health is too important. It's true, your health is important. But did I need a CT scan for a growth that I'm sharing too much information with you guys, but in my bladder, I had some small growth that the doctor said I should probably get a CT scan. It's $2,000, but there was another imaging that could have been done for $500 that was just as good. He doesn't care about that, but to me, that makes a difference. So, and if I do get the CT scan, should I pay the $2,000 one or the $800 one? All of this is opaque to the physician and the patient. It's in the shadows. And so it's not quite as nefarious as the drug deal that I have going down here in one of my images here. Not quite that bad. But the point is, when you don't know how much things cost and other people are controlling this on your behalf, that is not a good thing. Maybe this is a little bit more. This is from the movie, I forget what it's called, but so here she is shopping in Target blindfolded. This is what healthcare is like. your physician and you are making decisions on what should or shouldn't be done and who I should get it done from. And you have no idea how much things are going to cost. So you should know that up front. Just knowing that is going to create market forces that not only keep prices down, but ultimately give better quality care. That's kind of what was proven by the 200-year plus American experiment. That's what markets do, compared to, say, what happened in the USSR. So not that capitalism is the most popular concept to this last year, but it's what has led to the great prosperity overall in free societies. So look here, for example, about the relative cost of healthcare. So if you look, the gray is overall inflation and the black is workers' earnings. So basically salaries have not increased since 2000, and this is up to 2010, but the trend has continued since then. And then you look at workers' contribution to healthcare premiums, and that has increased dramatically. All of the increase in pay you would have gotten at your job is going to the benefits that your employer has to provide you. This is a problem. So this has produced wage stagnation. I don't want to take up your time by watching a video, but for those of you that get my slides, please watch this video. I don't know if you've ever seen Adam Ruins Everything, kind of an entertaining video, but it is entirely true what he's talking about. And basically, he's talking about the pricing structure that hospitals use in what they call the charge master. So these are the negotiated prices they have with the insurance company. So this is where you get the ridiculous $500 for the Tylenol or the $3,000 for the MRI. That's all negotiated between the provider and the insurance company. You, as a physician and a patient, know nothing about that. You're not part of that equation. You're not considered important. So, but then you're going to get the bill later. Now, when the insurance company pays, you don't really care. Who cares if they're charging you 4 times what it should be, as long as somebody else is paying? But
of course, I was.
Oh, actually, I was going to play. So, but I don't want to suck up time with watching a video. So the point is, now that we have large copays, and here's in deductibles, and this plot shows the increasing size of the deductibles. Now you have to pay what are arbitrary prices. Before, you didn't have to pay arbitrary prices. The insurance company did. And then the insurance company increased your premiums every year. And that was the previous slide. But now, not only do you have to pay the premiums, you actually have to pay the deductibles for the inflated price of the MRI or whatever. My daughter, for instance, has some medicines that she takes for, well, I won't say what it's for, it doesn't matter, but it's over $100 for, I think it was $150 for a prescription script for a bottle. She can go to GoodRx and get the same thing for $25. So that's an example of drugs, but same thing with an MRI. So you most times would be better off not using your insurance and paying cash than using your insurance and paying the deductible. Because again, the deductible is paying charge master prices, which are artificial. So you'd be better off not using insurance most times. I think we are now at a tipping point in America. That is like the reality, but people cannot accept it. People feel paralyzed by the need to use insurance, no matter how expensive it is, because they don't think they can get healthcare without insurance. So what are we paying for insurance now? So private insurance. So the total for healthcare spending in the US is $3.5 trillion. About $1 trillion of that is for Medicare, Medicaid. So if you extrapolate Medicare for all to the whole population, it will be more than the US pays, not only for healthcare, but for everything. That is more than we collect. So if you expand Medicare to everybody, it is more than the government collects from all tax revenue overall. So, but right now, Medicare, Medicaid, which is public insurance, is about a little more than 1/3. So about $1 trillion. Private insurance is another 1/3, and then out-of-pocket and other things is another 1/3. That's the number, $3.5 trillion. That's what we pay. It's a lot. So it's kind of interesting to me that when politicians talk about healthcare, they don't talk about this. They talk about how do we pay for it. So I like to joke that the medical industrial complex must be pretty excited that we never talk about why they're being overpaid, We only talk about how to pay them. Should we pay them from individuals, from private insurance, or from the Affordable Care Act? That's all we're talking about. But what we really should be talking about is, why is healthcare overpriced in the U.S.? And it doesn't matter how we pay for it, because if the government pays for it, you're still paying for it. It's the same thing. So we need, no matter what, we need price transparency, the ability for people to shop when you can shop, not when you're having a heart attack, in markets and competition. And we need to get rid of monopolies, anti-competitive behavior, like the Barbara McInerney from the AMA was fighting against. And we need to decrease the barriers for patients to be able to move around and shop and work with their physician. And that requires, in my opinion, a more ready control of medical records. So I can go to any doctor I want, and I have with me my medical records. I don't have to ask permission from Aurora, Ascension, or whoever, and wait 3 weeks for them to give it to me and say, why are you asking for this? Why do you need this? So it should be mine. They should be asking my permission for it, not the other way around. So $3.5 trillion spending on healthcare total. Well, what is the total revenue for the U.S. government from U.S. taxpayers? $3.5 trillion. So I don't know where we're going to find the money to pay for this. If we took all of the tax revenue and we stopped doing, defense and education and all the other things government does, then we could pay for it. So obviously we're going to have to tax people a lot. You're not going to get that much money from the top 1% of people that you tax. So again, I argue the issue is especially, why is healthcare overpriced? That's what needs to be addressed. So consumerization, empowering patient physicians, that's the key. So Trump was a bombastic person, and I think he annoyed a lot of people. I am not going to be a defender of Donald Trump per se, but what I will say this is, if he did some good things, if you don't like him, don't do away with the good things that he did. Use your head. There are some good things that he did do, whether you like him or not. So the executive order forcing price transparency and quality which came in part from Seema Verma, who was head of CMS at the time. That is a good thing. You should be able to know what you're buying and what you're getting. One of the reasons I know it's a good thing is that the hospitals sued to prevent this from going through, because they don't want price transparency, because they're overcharging through their charge master to pay for their big infrastructure. So they challenged this and they lost in the courts. So we now have price transparency. Hospitals, as of January 1st, have to be able to provide, in a very understandable way, prices of everything they provide, or pay a penalty. Now, the interesting scenario we're in is that a lot of hospitals are choosing to pay the penalty, because that's better than letting people know what they're actually getting. So here are some quotes. I was working with a local healthcare provider. They were trying to develop some tools to provide price transparency. And it was just fun for me to be listening to these things that, they're the person who runs Epic software, the IT person, and others were saying, how can we calculate prices up front? Can we actually do that? Can we do that? Can we tell you how much it's going to cost to get a knee replacement? Because it's like, you got to pay the anesthesiologist, you got to pay the nurse, what's the cost of the room? Amazingly, nobody knows that. The only time they figure it out is after you have it all done, and then they send you a bill. So the surprise bill to you is a surprise bill for everybody. Isn't that remarkable? They don't know how much something's going to cost before you get it. And then this is my favorite quote. Somebody said, what if our prices are higher for the same thing? Won't people go somewhere else? I thought, wow, you just discovered capitalism. Yes, if people get better care and better outcomes somewhere else for a better price, they will go somewhere else. And isn't that a good thing? So here, just for your references, this direct primary care trend is, I would argue, a revolution. It's happening now. Here are some places where you can get direct primary care, so you avoid the big conglomerates. Not that I'm advocating getting your healthcare from Walmart and Walgreens and others, but who can take on the medical industrial complex? I would say a consumer-driven revolution analogous to Uber, or an equally large corporate entity like Walmart. So Walmart is starting to provide clinics that provide primary care, dental, mental health counseling, labs and x-rays, health screening, optometry, the whole package. They will post their prices up front. People are going to go there without any insurance. And I can promise you it'll be way more cost effective than using what you do use with your current insurance. So not that I think we should get our healthcare from Walgreens and Walmart. but I'm happy that they are putting market forces at play here. So former Apple CEO believes that this is a revolution, a consumer revolution in healthcare. I am all about a consumer revolution. I'm all about empowering you as physicians and patients. So if that's what this is, I'm happy. Telehealth is going to be amazing in terms of access to resources. PAM is a local company that provides direct primary care. And again, I do think you need to go in to see your physician, but this is a resource and a tool that is really going to take off after this last year as well. Now, this whole idea of direct primary care actually works for surgeries too. So you guys, if you haven't heard of Dr. Kiesling, you've got to look him up. He's amazing. He has a surgical center in Oklahoma that provides direct pricing on all kinds of surgeries.
And just jumping in, for those of you that have been here before or for those new here, we spoke with Dr. Smith probably about 6 months ago and on our virtual event series. So we can send out the link to his video as well.
Awesome.
Yeah.
Yeah, he's incredible. A lot of people will say that the things that I'm telling you about right now, direct primary care, doesn't apply to things like surgeries. Dr. Smith proves that it does apply to surgeries. He hasn't increased his prices since he started. I don't know how long, 10 years or whatever. And they're all listed. He can tell you what our providers can tell you, which is how much things cost up front. And that is a healthy thing. So, and then electronic medical records. Like I said, if we have access to those and we can go to Dr. Smith if we want. And Dr. Smith has our medical records because we have them. I think that's a good thing. And there was some legislation that went through that, again, came from the Trump administration, the ONC Cures Act, that is going to enable this. And lo and behold, who's opposed to this? The medical industrial complex, EPIC, which is, by the way, based in Wisconsin. So don't get me in trouble with EPIC. A lot of our students go work there, but I wish they were not so anti-competitive. The software tool is being used as sort of an anti-competitive tool to keep you locked into the provider. The ONC Cures Act is going to create a software API that lets you go other places. And I'm working with physicians and surgeons that are trying to create software tools that really get information that they need to them and to their patients. And the barrier to this working is the electronic medical records, Cerner and Epic and that sort of thing. So of course they're going to lose money if this happens, but that's kind of the idea. Market forces, get better things at lower cost. So the goal of healthcare is not to keep Epic, rich. So here's some of the legislation, not legislation, but regulations that are in play here. So again, if you don't like Trump, that's fine, but he might have actually done a few good things. So don't shut them down just because of politics. I think everybody should be able to agree putting information in the hands of patients and physicians is good, and price transparency is good. So let me touch on a little bit on the blue end of the spectrum in universal healthcare. So should we have some sort of safety net? And how could we do that? So what I would argue as somebody who's sort of inclined towards free markets is if you're going to do that, do it in a way that still lets markets function. So Milton Friedman, famous Nobel Prize winning economist, said there are 4 categories of spending, whether you're spending on yourself or other people, and whether you're spending your own money or other people's money. It should be intuitively obvious to you, I hope, that if you're spending your money on yourself, you're going to be in this category. So that's category 1, your money on yourself. Category 1 means you're going to be careful about how much you spend, and you're going to try and make sure you get the most value for it. Obviously, if you're spending other people's money on yourself, just consider the company-sponsored dinner out. Yes, I'm going to go for the $40 porterhouse steak because, not necessarily. I do care about the company, by the way, so don't tell my bosses. But what incentive do you have to not overspend if you're spending other people's money? So that's category 2. So the point here is, how do we incentivize? This is economic principles upon which our country was founded, by the way. So how do we incentivize people to do the right thing? So what if you need to help people financially, if the government wants to help people financially, perhaps they could do something like a health savings account voucher. So put a little money in a health savings account. That money can only be spent on healthcare through direct primary care. You're going to get probably 4 times better care for the money if you use direct primary care rather than paying inflated charge master prices. And the money that's left over in this account towards the end of a person's life is their estate. They can use it as a retirement account. They can pass it on to their children. It feels like their money, even if it's government money. So that is the argument. And I have an economist that wrote on this in my book as well. So, by the way, this is how Singapore does it. Singapore has wonderful healthcare. They spend 2.5% of GDP versus our 18%. Not that we are Singapore, and I know there's many reasons why we can't compare ourselves, but I think that's part of the reason it worked. So the argument is perhaps have high deductible plans and give people HSA accounts. Could be paid for by the company, could be paid for by you. So that would be sort of a universal baseline. I would argue that if we go the Joe Biden route and we have some sort of universal baseline care that's paid for by the government, kind of like the Bronze Plan from the ACA. But by the way, if you know anybody on the Bronze Plan, it is ridiculously expensive. But kind of like the Bronze Plan, I guess Biden would be proposing that it's paid for, so it's free. You'd still have a deductible though, but we need to have levels and tiers so you can buy higher levels. And you need to allow people to not be forced to use the government-sponsored care. Because I can guarantee you, no matter all the wonderful promises from politicians, anytime the government completely controls resources, you will always have limited quality and rationing eventually. So Canada has that to some degree. This is sort of maybe a little bit of hyperbole, but this is Boris Yeltsin when the USSR, the wall came down and he came to America. What do you want to do? He wanted to visit a grocery store. One of the most powerful people in the world. He wants to visit a grocery store. And he said, if the Russians see this, they're going to revolt. So this is what free markets produce. They produce good quality products at reasonable prices. Governments are not able to do that. So I would just argue that if you want universal care, just make sure that you also allow tiers that you can purchase, and you also allow people to purchase directly in addition to the government, like Germany does, like Switzerland does, like so many countries do. Not like Canada. Canada doesn't do that. Canada has, in 2016, they had 63,000 people leave the country to get care because things like hip replacement, knee replacement, they had long wait times, 180 days average wait time for hip replacement. They don't want to wait as well. So just forcing complete government control is a problem. And I don't want to say things bad about Canadian healthcare because it is nice to have universal healthcare. I agree. I'm just trying to put a little balance here. We should have complementary markets as well. And this idea of, treating healthcare insurance like real insurance actually came from David Goldhill, who spoke at a conference we had last fall. Awesome book. You should read his book. My book, I'm not trying to sell books. If you guys contact me, I'll send you one for free because we got a grant for this. So I am trying to sell David's book though, because it really describes this concept of using insurance like insurance. So the idea is you have a car and your carburetor breaks down. You don't use your insurance, you pay cash for that. If your car is totaled, you use your insurance. He's arguing, and I'm not going to cover in 1 minute the logic behind why that works, but he's arguing, let's use insurance, healthcare insurance like insurance. When you need open heart surgery or something big, use insurance. When you don't, use HSAs and pay cash. He makes a really good case for why this is the right way to do healthcare. I would argue, since we have ridiculously large co-pays now and deductibles and high deductible plans, we have the start of what David Goldhill is proposing. So the difference, though, is with the model we have right now, all of the power has been given to other people. It has been given to the government or insurance providers. We could spend the same amount of money or less, but the decision-making could be with the physician and the patient. That's where it should be. That's what consumerization is about. So yes, I'm trying to start a revolution in healthcare. We need to consumerize healthcare. We need to empower patients and physicians. That's where the decision-making should be made. So the bottom lines are, we should embrace the telehealth revolution that COVID enabled. We should embrace consumerism, direct primary care. And part of that is moving away from paternalistic medicine, where the patient is not part of the equation. The patient and physician work together and they're empowered to make decisions. And then finally, we should treat insurance like insurance and not like some sort of subsidized healthcare where we've given all the money ahead of time and then we yielded all the power to other people just to waste our money. So that is the revolution I'm hoping for. I come from a healthcare startup world. I see waves of innovation and revolution. They go together. Here's this one example: is a direct primary care company that is now in multiple states, just raised $225 million venture round to provide this sort of new model for delivering healthcare. I hope they succeed because it's about empowering patients and physicians. $150 a month gets you 24/7 access to a doctor. Doctors get to practice medicine the way they want. They're not stuck in this machine that's burning them out. So this is the way healthcare should be. I have a nice video with Barbara McInerney, former president of the AMA, talking about all this. She is very much opposed to what she calls the medical industrial complex. And last but not least, a little commercial for Concordia. I think U.S. physicians have a duty to think about the economics of healthcare because it gets at accessibility. You want to provide good care to as many patients as possible. You don't want them being bankrupted by the things that you're doing for them. Obviously, you need to get the best care possible. But I just think, and Barbara McInerney talks about how to be a good physician, she recommends you have some sort of business education. So whether it's from Concordia or not, we have an MBA and a doctorate of business in healthcare. I do plead with you to please think about the economics of what you're doing and how it impacts the patient. So on that note, I think I am done. If there are questions, I would be more than happy to answer them. So
I think ending, me, we've spoken about this at length. Me, that the ending with the MBA plug is a big win for me. We have students currently in 5-year DO or MD, MBA programs, which I love. I think it's just such a need right now to either look at the curriculum of medical school to add more, or it is just a necessity. I have my own daughter who's looking at medical school or farm school. And I said, you have to do it. It is something that is a necessity to you. And I hope that everyone listening to this now, whether, we have a number of supporters on as well, it's something for you to think about as well as you're looking at your own personal advocacy, to remember that this is something important if you're seeing advocacy come around. We just had one of our supporters say, I love the idea of business knowledge for doctors. It's wildly important. For our students that have texted me about you supporting Dr. McInerney, I loved her. I think here's why they say that. I have another personal soapbox issue with the AMA. This is a Rebecca thing. Yeah. And it's because I feel that they've gotten too involved in influencing policy that isn't scientific based, and trying to influence medical school. And what medical schools are putting into their curriculum. Yeah. I think she, however, was a fabulous leader of the AMA. And I think, a number of the things that you said were part of that reason. I think she did a fantastic job at leading. And I think there's been subsequent issues that have moved it in different directions. And that's the way it is. That's the way, we see that with leadership in any organization and in the government. So we have a lot of questions. One of the things I wanted to say, first of all, if you mentioned Goldhill's book, Catastrophic Care, I do not believe that we have had a speaker on that has not mentioned the same book. So medical students that are listening to this, you guys have some of you have some downtime this summer. If you haven't read it yet, please let me know. We probably have some copies around, and I will get you a copy because it's a book you have to read. Have to. Also take Dr. Sem's, take him up on his offer and get his book as well.
I got a big box of them.
Read these books. These are great. You're going to get a lot of information. So going to some of our questions, I'll start with here on Zoom.
Yeah, I saw some on Zoom there. There was one that said he didn't agree or she didn't agree with universal health care. And I have to say I agree with you. I don't think we should have universal health care. What I do say though is that because we can be preaching to the choir, we're all free market people, I'm guessing. So, my point is to non-free market people is, look, if you're going to make this happen and we don't want it to happen, do not squelch markets. So that is my point. So,
and I think that was a great point to make, because that is something that we have. Our student leaders get a question about a lot, and you did a great job at talking about one of the big concerns about people that are students, at least, and I'm sure some of the physicians can talk about this as well. People get a lot of we're ethically bound to provide universal health care, to provide health care to everyone. And that's true. I can see that point, which is where the universal health care argument comes in for a lot of physicians. But I think talking about the ability to offer that competitiveness and that, the opportunities is important. And it's not saying you can't do that. It's not saying we can't offer universal health care. It's saying we have to offer those opportunities.
Right.
Did I get that right?
Oh, yeah. And I think there was another comment about morally safety net should be private charity. I don't think the government should be our moral actor. And I mean, if you wanted to debate with me about whether healthcare is a human right, that is a long discussion. I don't know that I believe it is. How many rights are there? My point is, we as individual moral actors are where these decisions should be made, not from the government. The government shouldn't be the moral actor on our behalf. Adam Smith, the advocate of the invisible hand in markets, wrote first about morality, and his assumption was that society is comprised of moral actors acting in their own self-interest. But part of your own self-interest is we're human beings and we have love built into us, and I think we want to help. I don't want the government telling me to help people. I want individuals to help people. So I agree. I would rather have it in the hands of private charities and individuals making these decisions. And frankly, direct primary care doctors, they're making a lot of money delivering medicine in a better way. They can decide if they want to do something charitable, and they probably will. I think that's going to be far more efficient than having the government do it, because everything the government does is inefficient. I do have to say that one of my goals in writing this book is not to win over people who think like me. It's to get people who don't think like me to see the logic and to let them know that they shouldn't discount. We live in such a polarized world right now. If you use the wrong word, suddenly half the people are not going to listen to you anymore, even if you have good arguments.
Absolutely. And that's, that is something that our students run into a great deal. Sometimes it's even getting their chapters approved to be chapters, because the Benjamin Rush Institute, we don't use the word free market often when the students are starting up chapters, because free market can be associated with the evil right or things like that. And we're not a political organization, we're an education association. So I get that. And that's why I think this talk is so important, because it really is explaining and giving those alternatives and the why. One of the questions was, we're very proud of our role and our students' role in helping push Seema Verma's transparency rules. Our students did a lot of commenting, and they were really talking about it a lot on campus. And it's through our work with an organization we belong to called Free to Care. We know that hospitals, not all hospitals, are taking it seriously and paying the fines instead. How do we get them to comply better?
Yeah, I think I'm not sure I'm articulating this the best way, but by shaming them, I think, what argument do they have for not being transparent with us? It's just not right. They need to be called out on this. So I think, we need to empower us. We as physicians and patients should be more vocal about it. Why is Hospital X not posting their prices? What are they hiding from us? I think we need to be more aggressive about calling that out. I'm a libertarian at heart. If I can confess my political leanings, okay, yes, we could have the government find them more. That is one way for sure. Right. So, But, I think, why don't we as a society push it more? I think we've learned a kind of helplessness about healthcare markets. We should demand to know how much things cost. So,
yep. And it's going back to the catastrophic care thing, you use it like car insurance. And
yes.
with car insurance, you have the ability to shop around, and you're going to go to who provides better care for your car. And you're going to go to the cheapest person if they provide good care. And we don't have that ability. We're just lax. We go to who our insurance companies tell us to. And we need to take back that control. This is a great question. Currently, Americans who reach 65, you must enroll in Medicare. So if you have a DPC doctor with a smaller fee, now you must pay more for Medicare. Do you advocate allowing citizens to choose which they prefer, Medicare or DPC? Direct.
Oh, absolutely. Yeah. I mean, just to use the kind of education analogy, the other highest cost thing in society that's overpriced is education. You should be able to choose a private or a public option. And you should get your tax dollars to be able to pay for the private option. Now, not only do I think that you should be able to choose the direct primary care, but why not, like we do with education and vouchers, is if I'm not using my Medicare, Medicaid, then give me some of that money that I put into the system back to pay for the private option. So I would agree and go one step further. So.
One of the questions that I ask everyone since we started this, and you started off your talk with this is, the students are getting ahead of me because they're asking it now. Thanks, guys. Is we have seen a number of regulations be put on hold or ending because of COVID throughout the country, both state and federal. And I always question, well, if they got put on hold for this, why put them back? What do you think are the most important ones on your side that we should look at seriously or first at not bringing back?
The regulations that have been sort of loosened from COVID. That's what
Correct.
The question is.
Yes.
I mean, again, I'm not myself a healthcare practitioner, so the one that I'm focused on, but maybe it's because of the people I'm talking to, are all the loosening of regulations that allow delivery of healthcare through telehealth. I think that has been really powerful. And even if you argue that telehealth isn't the best way to get care, it introduces a market force. If I can get what I need from a physician for $100 online versus $400, letting that continue is going to put a market force in place that is powerful and good. So I think just the loosening of regulations that allow the delivery of care remotely and the delivery of care across state lines is a good thing. It's a loosening, and let's keep with that. We need to crack the door open on consumerization. I feel like that did it. But again, I'm not a healthcare provider. There could be others that I'm not aware of that are.
Yeah, we've had a number of different answers to that. I think telehealth restrictions is pretty much the biggest, that between policy experts and physicians that they've said. We've had a number of DPC docs speak to us, and it's kind of the pat on their own shoulders that they've been doing telehealth for years. And other primary care physicians, non-direct primary care, but primary care physicians went to them for help at the beginning of COVID, saying, now what? The problem now, I think, is like the duality of pay and how to look at that payment model if we are going to continue with telehealth, and what to do about that. Are they going to, and again, going back to payment, what are we going to do about that? Are telehealth services going to be charged the same way through insurance?
That would be bad. If we charge at the same high price. So. Right,
exactly. And I think that's going to be a huge battle because nobody wants to lower a price.
Right.
So there's been a lot of questions to talk about pharmaceuticals, by the way.
Oh, I love pharmaceuticals. But
I know you do.
Another hour. So.
So we did something you mentioned, but you didn't go into a lot more, is Dr. Smith and doing things like surgery. Something I always stress with the students, and I think we talked about, you don't have to do you don't have to do primary care or internal medicine in order to do direct pay services. How does that business model look? We talked with Dr. Smith about other things and not just setting up a practice. We happened to talk to him about the day, and it was kind of, I don't know how it happened, the day that the CMS rule came down on transparency. And it was great because you're talking to kind of the grandfather, poor guy, of transparency. He was doing it first. But how do you set that up? If you are a medical student right now that is thinking, this is the kind of doctor I want to be. I want to be someone that can advocate for my patients and have that relationship no matter what my specialty is. What is the foresight? Like, what do you do?
So if you're a young physician and you basically want to be Dr. Smith, so
something like that. Yeah.
I mean, I think there's a need for it, and Dr. Smith, and you had him, so best to talk directly to him, but he obviously doesn't like insurance. He sees the dysfunction that we all see. So, but there are third-party administrators that run something like self-pay insurance that can work with people like Dr. Smith in a transparent and correct kind of way. So there are ways like Concordia, we're self-insured. By the way, I mean, self-insured companies can be nimble. They just have to open their minds to a different world where, for instance, we could do everything through the company, that it's all paid for by the company, except for that rare time when somebody has $1 million infeasible cancer therapy. I think self-insured folks need some sort of stopgap because it'll bankrupt the self-insurer. So one way to be a Dr. Smith kind of person is to connect with self-insured payers. And those people, they themselves need protection from catastrophic things that happen to their employees, because you can have one employee that can bankrupt the whole plan as well. But I think there's this trend towards direct primary care. I showed you venture capital financing for one. The future Dr. Smiths of the world are going to tap into an infrastructure that brings patients to them as well. So, I mean, if you're going to run a surgery center, that's more specialized than direct primary care. If you want to do direct primary care, I would just say there are plenty of those popping up all over. And I wanted to use our local direct primary care. He can't fit me in. He's got like 400 patients. So I think, you just need learn a little business, learn that you don't have to get sucked into the medical industrial complex and talk to a couple of people that do it and do it. But if you want to be a surgery center like Dr. Smith, that's a little bit more complicated. So, but I think it's doable. And I think the market is moving in that direction. And the people that are going to pay you are maybe going to be self-insured companies. So.
Yeah. And, we talked to one of those, and he hates the word brokers. His name's Carl Schuessler, a couple months ago. And he's one of the people that he doesn't deal with the big, with the Blue Cross, the United. And he and his company and people like him deal more with the Concordia universities that are ready to do that, to privately fund outside of those big businesses and to look at physicians, including things like DPC, and do it that way so that you can have more control over your insurance and over your healthcare, or through your healthcare and who your providers are, instead of being told who you're allowed to go to. So for those of you listening who have different interests in different specialties at this point in your career or in your schooling, just understand that is a possibility, and they are getting more. While even 3 years ago, the map of DPC doctors was sparse throughout the country, it's getting bigger and bigger and bigger. And I can send you the map and what that looks like. Even when I started, I say 3 years ago because that's when I started at BRI. And now it's getting more. So that's what it's going to look like, hopefully, for other specialties. That was, I think, I'm looking all of my questions currently. Remembering that this is going to, I have one more. This is going to be recorded and put up on our YouTube channel. I'm going to share, with Dr. Sem's permission, his contact information with everyone here, including links to the think tank, to his information, to Concordia University, which I hope you do take a look at the MBA program, because it's wonderful. I don't even have to go on my soapbox today because he told the information. And a number of the other resources that he mentioned, I will put into that follow-up email. Remember to go to the BRI YouTube channel to get any of those past videos and to sign up on the BenjaminRushInstitute.org site for our newsletter if you aren't already, to learn about future events. Dr. Sem, this was fantastic. And I know that I will be utilizing this a lot and sending it out to a lot of people. I do want to ask you back to talk about pharmaceuticals at some point. Students, if it is something that you want to do on campus, let me know as well. That's how Dr. Sem has spoken on one of our chapters, at one of our chapters before, which is I'm learning connections all around. And so we can do that as well. So I'd have to ask first, but I'm volunteering him.
Yes, I'm on board.
So thank you all very much. And we will talk to you next month.
All right. Thanks, Rebecca.
Thank you so much.
Bye.
I hope you enjoyed today's edition of the Benjamin Rush Institute's virtual events series. To learn more about our educational programs and events just like the virtual events series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's virtual events series.